Good afternoon. Thank you for joining the respiratory department meeting for May. We are at noon exactly, so we'll go and get started. A little bit of a brief agenda uh, for this month, so we should be able to get through it pretty quickly. We'll start off first with a reflection. This is an author, Marianne Williamson. Each of us has a unique part to play in the healing of the world. I thought that was a very nice quote to start things off with. So, in brief, we're going to go over TJC when we think they may be arriving again. We'll go over accounting, current events from our rescheduled hospital skills fair to other items that are going to be coming up. RT equipment, um, team expectations, employee satisfaction. This likely will be the last employee satisfaction question for the 2024 cycle, as the My Voice survey is coming to a close, effective at the end of the day today, actually. Some hanging slides regarding education, Unit-Based Practice Council. Neither Danielle nor Carrie are on, but I have been in communication with them as to what they are currently working on, so I can speak to that. Scanning scores, some updates regarding positions, kudos, and then open forum questions. So TJC, there was a big push to really kind of dial things in earlier this month. TJC visited several hospitals within the region from Sutter Downtown to Mercy San Juan to Mercy General, and seems to have kind of blipped off of the local radar. The consensus now within the hospital leadership is that perhaps they will be coming in July. This is based on the fact that previous inspections had happened during the month of July towards the mid to the end of the month. So that isn't to say that it's guaranteed. There are no guarantees when it comes to these inspections, but as soon as I know, obviously, I will relay this to you all. Um, just a few tips that everyone is really good at anyway, but it's worth mentioning again. Your PHI for the work that we do, if you're working with a WOW and doing charting, making sure that if you're not immediately in front of your WOW, that you are logging off the computer. This has been found in different departments, not necessarily RT, but it's not good enough to turn off the computer monitor. You actually have to log off. There are surveyors that will go around, notice a computer monitor that is off, they will turn it on. And if a lock screen comes up, that's perfect. If patient information or patient chart comes up, that's not good. So just one tip regarding what our normal practice should be, but especially in light of our TJC survey, which is coming any day. Accounting. We again are doing fantastic. As you know, Ina and Andrea have been going through some orientation processes in getting cross-trained into EEG. Huge shout out to them both. They're doing a fantastic job. But of note, our productivity gets hit directly when we're doing orientation, whether it's special orientation for pulmonary rehab, EEG, PFT, that comes directly out of our productivity. Fortunately, we have a good buffer there. We're at roughly 128%. We're looking to close out this fiscal year extremely strong. And hopefully we're able to start onboarding our per diems as their onboarding again would go off of our department productivity. So long way of saying that this fiscal year we have done fantastic. And our year-to-date overtime is also beneath the threshold of 2% year-to-date. It looks as though we are going to be able to meet target there as well. So great work. All right, so hospital skills fair. I had mentioned this in our Tiger Connect maybe late last week. The hospital administration has made the decision in light of our potential survey and other factors to postpone our hospital skills fair days. It was to have started this week. Obviously, that didn't happen. We do have some new dates that have been identified and listed on the slide right now. They are the beginning of September, and then keeping with what we had as the second uh, time in November. They're both roughly a week worth of days, both in September and November. So moving forward, just like what was attempted for May, this will be incorporated into your schedule, and I'll be signing everyone up for days, and that will be posted. Uh, so yeah, more to come there. Nothing with regards to the skill fair, like content is going to change. They just had to switch the days. Some exciting news after a lot of back and forth with CLC and HR, finally found a way in which we can give credentialing to our students that visit us. So that is our RT students that shadow us that we've had from SJVC and ARC. They are plugged into our system and now have the ability to have a unique log on to our Cerner charting systems. This has been tested already with 2 of our students so far and has worked with no with no issues, rather. So just to be clear, the expectations, this was a question that came out early on. The expectations for the RTs of the department, nothing is going to change with regards to your workflow. Everything that you have charted before, everything that you build before, you're still going to be responsible for. The intent of going down this path of allowing our students to have access really is more so they can be familiar really with Cerner charting. There are organizations besides Common Spirit that utilize Cerner charting, so they can have some firsthand experience under their own login navigations through that space. It should be able to help them as well when they're doing their case studies, as opposed to having to have your access to review charts. They can do so when they have downtime to make notes for themselves. Beyond that, they are able to chart minimally, albeit things insofar as assessments. They can chart in ad hoc breath sounds. They can chart vital signs. They can even chart in iView if the patient that you are caring for is on a BiPAP vent or otherwise. The intent is that the preceptor is going to not only be showing the workflow for the student during the first rounds, but also showing them the ropes, so to speak, as it pertains to what our expectations are for charting. This isn't to say that they're going to be replacing us in doing the charting, nor the responsibility is not going to fall on them for charting, but this will be kind of an opportunity, I guess, for double charting so that our students get some experience in doing that themselves. So it is excellent for a learning opportunity, kind of is able to put the whole picture together, more or less, when it comes to understanding the workflow of the environment as a respiratory therapist, at least here at Woodland Memorial. So very exciting. It's been a long time coming. Happy that it's finally working. RT equipment, again, this is a hanging slide. Just again, everyone's really good about this. When you're finished or when a patient's finished, discharged, no longer needs whatever piece of RT equipment that we have had in the room. Uh, remember to clean it, dress it, bag it, tag it, plug it in if it needs to be plugged in, if it is operated by a battery or has a backup battery. So Airvo 3, been talking about this for a few months. Wanted to make sure that we did the right thing and had the appropriate education before we rolled it out. It may seem redundant, but it's super important that everybody has the opportunity to get the education before we roll out a new piece of equipment. Obviously, this is just a little bit of an update for relative to our Airvo 2. However, I've created pathways to go through this with everyone. The pathways come due at the end of this month. I believe just about everyone has completed that pathway. Once that is done, there is a competency that will be checked off. You can see that in the background of the slide. And as soon as all of that has been filed away and logged in everyone's employee file, we can finally get this out into the wild. It's set up on the fourth floor. It is missing, obviously, the components necessary for it to work. This is by design. Not going to install any oxygen tanks or equipment on it until everybody is trained and signed off on their competency. I don't anticipate this being a major issue, again, because it is extremely familiar with just a few updates from our Airvo 2. Gloves, PPE, infection control. This is again something I go over every month. It does get identified by other leaders, not just RT, but nursing. The appropriate hand hygiene and the appropriate use of gloves and PPE is extremely important all the time, especially important when we're in the window of survey. You cannot be wearing gloves outside of the room, outside of patient care. They may be clean gloves. You may know that they're clean gloves, but to the observer's eye, if you're walking or roaming the halls wearing these gloves, it looks as though they're dirty. Gloves really need to be donned within the patient's room during the time which you're doing patient care, then doffed as you're leaving, and then with the appropriate hand hygiene, gelling out or washing hands as it may be relative to whatever isolation your patient is in or not. Team, again, just a reminder, the accuracy of your clockings are your responsibility. It is imperative that you have an accurate representation of the hours that are worked, and that you're signing off that those hours are accurate at the end of the pay period. Just a hanging reminder that this is the ongoing expectation. All right, employee satisfaction survey. Again, like I mentioned earlier, this is likely going to be the last question that we review that is a part of the 24 bundle. Our 2025 My Voice survey comes to a close at the end of day today, and leaders will be getting reports soon thereafter. Just as a reminder, we at Woodland Memorial are still in the lead. We reached just today the threshold of 90% participation. So that will open another gate for a raffle for PTO as well. So those winners will be identified and disseminated out to the leaders so that if they are under if it's one of you guys, which I hope it is, I'll let you know. But yeah, that raffle should happen at some point today. But all that being said, this is the question that I had identified to go over for this month. And again, full disclosure, it's really hard to pick and choose questions to solicit opinions for, because generally all of the responses are fairly high marks. this is a questionnaire, 1 through 5, 5 being the highly rated and 1 being the most lowly rated. So this is at 4.05, and the question is communication between work units is effective in this organization. It's an organizational question, and I believe it pertains to, say, communications between, say, RT and let's say phlebotomy, or RT and nursing, or RT and radiology imaging, what have you. So while it is high, this particular question is low relative to the high marks and other questions within the survey for last year. So mouthful, clearly. But I'll open up to those that are on the phone, if you have any comments regarding this, or if you have any experiences regarding this where communication has been relatively ineffective. Um, and further, if you have any idea how that could be improved.
Um, I do.
Oh, thank you. Well, the floor is yours.
Okay. Well, I feel like an example would be like when we went through the rooms and we put in all the Y connectors, um, and then they were like taken out and they didn't know that they were supposed to be there or what they were, and it just got really messy and things were taken down and the flow meters were moved. And then when we were looking for them, no one knew where they were. And it was just like a messy, I think between like both departments, like we just weren't on the same page.
That's an excellent example. And actually, I take ownership of that one. My communication between nursing leadership was directly to Susan, but it wasn't necessarily to their leads. I think if I had more FaceTime with the nurses on both 2A and 3A, that might have produced a better outcome, and there wouldn't have been that much confusion. Information dissemination is tricky at best, but yeah, that's excellent, excellent example, Marissa. Um, so thank you. Anybody else?
I do have an example.
Shoot.
I think maybe I only speak for myself, but I've had issues communication with L&D, because a lot of times they call for you to go check the warmer depth, but they don't really give you any kind of rundown of, is this a high risk, if this is not a high risk. And a lot of times it's like when you're there, it seems like they're like they just want you to just check the warmer and kind of get out and not really be a part of the team.
That is some really distressing feedback. Hey, Kara, thanks for joining. Uh, Certainly, we are part of the team. We are considered an integral part of that labor and delivery team. And I'll ask you, please, if you could, and it doesn't have to be a lengthy email, please send me an email regarding those experiences that you've had, particularly in labor and delivery, and I can start having discussions with family birth leadership and kind of see what's going on there.
Okay. Oh, thank you.
Yeah.
Just, I mean, valid to each own, but not to discredit anything. I personally haven't had any of that experience. I feel like even when I go in there, there's a nurse there. I don't know her name. She's kind of new. I can't remember her name, but she like introduced me. Like I went in just to check it, and she's like explaining like what we're doing, why I'm there, who else is going to be in there. Just kind of like went over everything, which was kind of nice. It was like a good introduction for the family. And then usually they like tell me, and if they're busy, then I like ask about the mom and baby and all that stuff. But personally, I feel like they're pretty good about communicating that stuff, but I don't know.
Yeah, just a matter of perspective. It could have been a one-off. It's really hard to say. Kara, to keep you up in the loop or up to speed of what we're discussing, this is one of the questions
Yeah, I figured it out.
yeah, we're particularly talking about communication now between family birth and RT and the various experiences my staff have had regarding that. Some are very positive, some are negative, not being really verbose about what the patient condition is, leaving our RTs kind of in the lurch, not knowing what to expect when they walk in the door, if it's a low risk, high risk, or otherwise.
So just an idea. Is to get together with Xana and maybe create an action plan regarding this. Because really it affects both departments and as a nurse, I should be, I would talk you up. The respiratory therapist and introduce and say, hey, they're gonna be doing this or whatever, especially in handoffs and stuff like that. So that would be action items, right?
Yeah, totally agree.
And you want to get the staff involved on both sides, right? In developing, developing that. Now, of course, if the nurse is busy, et cetera, whatever, but if it's a critical situation, et cetera, that's a whole another thing too. So, just working through some of the scenarios that aren't so good. And then, but also always start with those that are good. Right, and I would do like a presentation of your action plan to both groups and what you have decided to do to work on, maybe 1 or 2 action items, no more than that, because it won't work, right? And it falls back and it doesn't move forward. So, basically we're in it to help and support each other, and we're trying to tear down those silos. And what I mean by that, you got RT, you got lab, you got radiology, and really we all need each other, right? And so that's some things that we're trying to work on, and really, it all comes down to the leadership support, and of course it starts with ourselves, right? The man in the mirror. So that's just a little tidbit off the top of my head here, but this is a great one to work on. I'm anxious to see, how the new survey and where those situations are going to be, but I would not forget about this one. And I love that you're bringing it up in your staff meeting. And remember, everybody, everybody should have some input to this, and don't be afraid to say something, right? So I think you can't change anything if we don't know about it. So especially when you're having scenarios where you're having problems, in that area, maybe with a particular nurse, et cetera, that's when Brian can get involved and really work with Xana and try and get rid of that type of a culture, in other words, right? Going back to our mission and vision, et cetera, and keeping that in the forefront. Okay.
Yeah, no, absolutely. I've already instructed one of my RTs that had brought up the communication lapses to email me, and then I'll speak with Xana, kind of get a fact-finding meeting going, and develop action items and plans subsequently. So, yeah.
Yeah, but sometimes it's a bigger picture. So, or there's a trend in the situation. And that's why I always like to get staff on both sides so they can hear each other. I mean, it might start off quiet. Maybe nobody will say anything. And that's where, a mediator being you can bring up a scenario, not using anybody's names, right? We're in a just culture. And, how would you feel if you, were told this, or you were embarrassed in front of a family, or maybe an opportunity where you felt you really needed to be taking care of that baby in the moment and we're kind of brushed off, right? So, yeah, so
Yeah.
that's.
Absolutely agree.
Mhm.
With that said, thank you, Marissa. Thank you, Ina. For the remainder of the folks that are on the call, do you have any experiences that you'd like to bring up regarding this?
Or am I so off subject? It's okay to tell me. I'm
No,
just
you're, yeah.
coming into this.
100% on board. I'm going to take that silence as a no, and we'll go ahead and move forward. And again, thank you, Ina and Marissa, for sharing. All right. Again, a hanging slide I bring up every month. We actually, Elvis and I used the education fund together. I helped walk him through one of his certifications that he wanted to be reimbursed for. It's a lot of information. It's extremely daunting, but at the end of the day, he was able to get reimbursed, and it was pretty seamless, actually. So free money out there for you, either brick and mortar institutions, certifications, licensure, whatever. There is stuff from Edasys that the company provides for, and your union that provides just annual money that's there for you. So if you have any questions about it, or if you need help navigating it, don't hesitate to ask. I'm happy to help. And Elvis just recently went through it as well, so he'd be a good resource as well. Again, just for FYI, these are the certification classes that are being held here at Woodland from our education department, whether it's ACLS, PALS, or BLS. Unit-based practice council, again, like I said, Danielle and Carrie are not on this meeting today, but I can speak to what they have been working on in the background. We are developing a narrative for our patients that are scheduled for EEGs to kind of give them a good understanding of what to expect. This kind of dropped off through the various iterations of the schedulers that we have had. Now that we're doing this in-house, we can really kind of control the messaging. So initial drafts from Carrie regarding what to expect and how to prepare look fantastic. We should be incorporating this soon. I've sent this over to Emily to kind of look over, but we should be getting this incorporated soon with our in-house scheduling. Beyond that, we're also working on developing a rough first draft of a RT protocol here for Woodland Memorial. Between the work that Danielle, Carrie, myself are doing, also having Dr. Robinson, basically our medical director for respiratory therapy, put in his 2 cents. I have to poke him a little bit for some feedback. Overall, he likes it, but hasn't really dug into it as much as I would like for him to. He's off this week. He'll be back next week. I'll be poking the bear once again and speaking with key stakeholders, whether it is our director of med staff or our CMO, to kind of get them apprised of what we're looking at. Initial conversations have been positive. They are looking forward to it, but just want to make sure that the hospitalists, our providers, are on board as well, because ultimately the development of trust between them and our department need to be there for them to feel comfortable in ordering this. And that is the extent of what they're working on. It's quite a lot so far. Hopefully either Carrie or Danielle are on tonight's meeting. They can speak more directly to it. Scanning scores, again, this is something that I go over every day in audit. Very important that we're scanning the right med at the right time for the right patient. Overall, you guys are doing a fantastic job. If there's any fallouts, I'm having individual coaching conversations with you. But like I said, overall, you've been doing great. Just as a note, if you come across a WOW or scanner that isn't working, please put it aside, place a ticket so that the next person that uses it will have a functional piece of equipment, so that we are doing what we are supposed to do, and which is patient safety, scanning the meds before we administer. Okay, Kara needed to jump to another meeting and says, always know we can't provide great care without our RT staff. Very sweet. Positions. We do have a couple of open positions. There is a candidate that I will be interviewing for the replacement for Andrea's spot. There is one night shift per diem position that will be a replacement for Tristan as she transitions over to Mercy San Juan. So if you know anybody that is interested, let me know. It isn't necessarily a done deal for this internal candidate that I'm interviewing. And as the new additional night shift per diem posts, it might go to external as well. So encourage anybody that you know that would be a good fit to our department and our culture to apply.
Brian, are all of these per diem positions RCP2?
The one that I'm interviewing for is a RCP2. The one that is upcoming is a RCP1.
And is that already posted externally, or is that going to be external soon?
It hopefully has been just posted internally. All of these positions post internally for 7 days. If there's nobody internally that applies, then it gets posted externally after that time.
Okay, thank you.
Thank you. Okay. And kudos. You guys have been saving these kudos. I know the last few months have kind of been hit and miss, but my goodness, this month, thank you so much for recognizing each other and the work that you do. Overwhelming, of course, Gary, for everything. Additionally, thank you, Marissa, for covering L&D when there were 2 unexpected C-sections in the evening. You're a rock star. I think everybody knows very well that Marissa indeed is a rock star. Thank you, Marissa. Holy moly, for all that you do in the EEG department. You're awesome, an awesome rock star. It's overwhelming, but all true. Kudos to Marta, Ina, Taylor for helping with an E-Bus Bronc on a very busy day. Yes, teamwork, of course, makes the dream work. Kudos to Taylor, who went through supplies and cleaned out all the expired things. This has been a team effort. I know I've tasked a few RTs to go and do that, especially as we're coming upon TJC survey. So thank you again for keeping an eye out for those. No matter how much you file through all of these pieces of equipment, invariably you find that there is something that's expired. So continued vigilance is greatly appreciated. Kudos to Mason for helping out with the EEG machine and login. Mason is a technical wizard, among other things. So thank you. Thank you to Mason, and thank you to everybody on the board and everybody in the department that does amazing work, but isn't necessarily recognized all the time for it. Thank you. And that is it. Pretty short and sweet. Questions, comments, concerns?
I have a question.
Okay, shoot.
So the whole thing with the students being able to chart,
Yes.
so we're still charting like us, right? Like we're still scanning meds.
Yes.
We're doing all that. And then
Yes.
they're charting. Is it going to be in there twice or?
It's
How does-
essentially, yeah. So I've kind of pared down what my expectations are for the students to chart. And this is just to make sure that they don't get caught up either saying or doing something that they shouldn't be. I want to, at the end of the day, make sure that the care that we're delivering and what is reflected in the patient's chart is accurate to what they're getting. So essentially, there will be, at best, there'll be some instances of double charting, but instances, say, that are kind of inconsequential. They're not going to be scanning meds. They're not going to be doing any kind of charges. They'll be going in to do free text on ad hoc forms for, say, respiratory assessments and typing in patient at such and such time had clear breath sounds bilaterally, good, they can list their vital signs and pulse, their saturation, respiration rate, etc. Physical assessment if they want, stuff like that. And then moreover, if the patient is on, say, a BiPAP or a vent, they can go into iView and put in the alarms. They can put in the volumes that the patient's getting. And while from an iView standpoint, this isn't to say that the RT that is assigned for that patient isn't responsible ultimately to do a full and accurate charting at the time of interaction with the patient for like a vent check, what have you. It just means that your student can also do it and just get experience in doing that. These are the two kind of lowish hanging opportunities for your student. So yes, it'll be double charted, but it'll be notated who is doing that charting, both yourself, the RT and the student in these very specific realms.
Got it. Thanks.
Got it. Perfect. Anything else? Okay. Well, thank you very much for your attendance and attention, and I'll see you all very soon. Have a good rest of your day.